Today we will be discussing about the fundamental principles of total knee arthroplasty. So what is the reported success rate? Overall, 14-year revision rate is around 4.47%. For CR it is 4%, that is cruciate retaining. For posterior stabilized knee it is 5.4, unicompartmental knee it is 9%, and patellofemoral joint alone it is 25%. The indication is pain not relieved by conservative measures affecting the activities of daily living. Contraindications are infection, neurological disease, vascular disease, and a deficient quadriceps. Surgical goals are pain relief and a functional improvement. There are technical goals that include achieving the weight-bearing axis passing through the center of the knee, making the joint line perpendicular to the weight-bearing axis, soft tissue balancing, restoring the Q ankle, and leveling the joint. We should know what is valgus cut ankle. It is an ankle between the mechanical axis and the anatomical axis of the femur. Mechanical axis is at 1.2 degrees of Paradis. So 60% of the weight will be passing through the medial compartment. Femoral rollback is another concept. The posterior shift in the femorotibial contact point in the sagittal plane as the knee flexes. That is called the femoral rollback. The total knee arthroplasty can be classified based on the constraint ladder. When constraint increases, conformity and thereby the aseptic loosening increases. When we move from PCL retaining to strain condylar hinged or the linked knee, we are actually moving from a less constrained knee to a more constrained knee. The two most commonly used constructs are the PCL retaining knee and the posterior stabilized knee. The PCL retaining knee is the least constrained one and it is having the least loosening. Preserves the bone stock and preserves the proprioception to some extent. Supracondylar fractures are easier to manage because there is no cam. Posterior rollback is the femoral rollback is found to be poorer in case of PCL retaining when compared to the posterior stabilized knee. There is more polyethylene delamination and the chance of PCL rupture and fraction instability is more in case of a PCL retaining knee. However, in case of a posterior stabilized knee, because it is more constrained, there is more aseptic loosening but less polyethylene delamination. There is more femoral bone loss. Anteroposterior stability is due to the cam. So there is a unique problem called cam jump. Another unique problem for the PS is the patellar clung syndrome. It is having a better rollback when compared to the PCL retaining knee. Soft tissue balancing is an important concept in total knee arthroplasty that include the mediolateral balancing and the flexion extension gap balancing. The mediolateral balancing include medial release for a tight medial side and a lateral release for a tight lateral side. The medial release is done in this increasing order, that is osteophytes, the deep MCL, semimembranosus, superficial MCL, pes anserinus, and PCL. The lateral release starts with osteophytes, the patellofemoral ligament, posterolateral capsule, and we have to know this. That is, LCL release will affect both flexion and extension tightness also. ITB and popliteus affects the extension tightness only. Biceps and gastrocnemius affects the flexion tightness only. The flexion extension balancing has to be understood. If the extension and the flexion are okay, we are in a perfect situation where there is no need of flexion extension balancing. If the extension and the flexion are loose, we have to use a thicker insert, and if the flexion and extension are tight, we have to do a bigger tibial cut. If the flexion is okay, extension is loose or tight, we have to either augment or resect the femur. Okay. If the extension is okay and flexion is either loose or tight, we have to either oversize or undersize the femur. So oversizing or undersizing will affect only the anteroposterior diameter, whereas augmenting or resecting will affect the extension gap. If extension is tight and the flexion is loose, we have to oversize the femur and use a thin insert. If extension is tight and the flexion is tight, we have to downsize the femur and use a thicker insert. So if there is a problem with flexion and extension, we deal with the tibia. If there is only one problem, we mainly deal with the femur. How will you take the tibial cut? There is a 3 to 5 degrees of posterior slope and should be perpendicular to the mechanical axis, and this is achieved using the extramedullary jig. Distal femoral cut is achieved with a 5 to 7 degrees of valgus angle, and should be perpendicular to the mechanical axis, and we do this using the intramedullary jig. The anteroposterior femoral cut, tibia is in 3 degrees of varus naturally, so this warrant an external rotation of the femoral cutting block to 3 degrees, which is achieved by keeping the jig parallel to the epicondylar axis, posterior referencing, or making the jig perpendicular to the right sides line. Femoral tracking is another important concept. Man tracking can be prevented by external rotation and lateralizing the femoral component and the tibial component, and only medialized component is the patellar component. This is an often tested concept in the part 1. About the patellar resurfacing, in general, patellar resurfacing is not done for all cases. In grade 3 to 4 OA of the patella, we may consider resurfacing. For other cases, we can do circumferential electrocautery. We can quote Barak's and Robert's papers during the discussion. Managing the patellar badger, use small patellar dome and lower the joint line. A valgus knee is a particular problem. We should know how to talk when such an X-ray is kept for your viva. We can start by telling that anteroposterior radiograph of both knees shows bilateral lateral component degenerative changes, which is more in the right side. There are valgus with the loss of joint space in the lateral compartment with sclerosis and osteophyte formation. These findings are consistent with osteoarthritis of the knee. I would take a detailed history to establish the cause and success of the conservative measures. I will examine the patient's gait. We'll do a full knee examination to determine the severity of the deformity. I will assess the integrity of the collateral ligament and correctability of the deformity to plan for the degree of constraint needed. I will also examine her hips and ankle for any deformity or stiffness. I will also obtain lateral view and skyline view. A long leg view would help me to determine the mechanical axis and the degree of the valgus. Complete blood count, C-reactive protein, and TSR is done to rule out infection if any surgical intervention is planned. The causes of the valgus could be An inflammatory joint disease. It is more common in females, can be post-traumatic, osteonecrosis may be a cause, and high tibial osteotomy could be another cause. Why valgus knee is requiring special consideration? It is usually associated with bony and soft tissue abnormalities. Lateral subluxation of patella due to lateral capsule and ligament contracture may warrant larger insert and there is chance of peroneal nerve palsy. Medial laxity may warrant a constrained knee. PCL may be elongated and dysfunctional. That may so we should keep PS knee for valgus knee. Deficient lateral contyle posteriorly and distal femur internal rotation up to 10 degree make posterior referencing uh, difficult and it is in general contraindicated. In general, the principles are we use medial parapatellar incision, the distal femoral cut using a predetermined valgus cut angle is done. Proximal tibial cut is with a 3 degree of posterior slope. Mediolateral balancing has to be done. Anteroposterior femoral cut parallel to the epicondylar axis or perpendicular to the right side line. Take care of the external rotation component.